Now, good afternoon. This is Dr. John Bennett broadcasting from Miami. Tonight we have another in the series of neurosurgical hangouts with the Larkin Hospital TV channel. Today we have Richard Mendel, again, neurosurgical educator from Tampa, Florida. He's going to talk about updates in glioblastoma multiforme. And first, we have a distinguished panel. We're going to go around and introduce everyone. First, we'll start with Jesse. Good afternoon, Jesse.
Hello, everyone. It's Jesse Contra from Philadelphia, Pennsylvania. I'm a second-year medical student. Thanks for having me.
Welcome, Jesse. And Yuri Curry.
Hi, my name is Kuriako. I'm a final year.
You're muted.
We can't hear you.
Oh, sorry about that. My name is Kuriakos Korean. I'm a final year health information technology student.
Welcome, Curry. His first hangout. Welcome. And Sarish.
Hi. Hello. My name is Sajesh. I'm a faculty teaching at Larkin Health Science Institute. I'm a maxillofacial surgeon, head and neck surgeon by profession. And currently I'm involved in the Larkin TV and all these programs on Hangout. Thanks for having me on the panel. Thank you.
Welcome, Sajesh. And Sajesh may be starting a head and neck channel also. and Simon.
Hello, everyone. My name is Simon Downs. I'm a developmental psychologist in Tokyo, Japan. And I'm also a second-year medical student. Nice to be here. Welcome,
Simon, and also one of the older members of the platform of the Hangout. Welcome, Simon, and Ben, welcome.
Yep, I'm Ben Mulpuri from Michigan. I'm an internal medicine physician. I'm one of the board members of this Hangouts, and I'm glad to be here once again.
Welcome, Ben, and Ben is going to we're going to redo his practicing medicine in rural India.
Yeah, sure.
And Richard, welcome. It's all yours.
Okay. You know, you can feel free if you have questions, just ask them.
Okay.
You know, I thought we would talk about glioblastomas today. You know, glioblastomas are a very difficult topic, and you know, they're very common. I had a friend pass away a few months ago from a glioblastoma. Another friend who's got a glioblastoma. You know, it's a very common. It's very common. It's the most common primary brain.
We're having a few audio glitches, Richard. Richard, can you hear me okay? Sorry, folks. Richard?
Yeah.
You're having some, we can't hear you a little bit.
You can't hear me?
Now I can. Okay, go on. Maybe that was a temporary glitch.
Okay, well, glioblastomas are very common, and they're very difficult to treat. And the mortality of glioblastomas has changed in terms of maybe a few months of survival over the last many decades. But we seem to have learned a lot more about the histology and molecular biology and genetic markers of glioblastoma. So in terms of GBM, the actual name glioblastoma multiforme, I think that came from Louise Eisenhardt, who was a colleague of Harvey Cushing's. And when you look at the autopsies of people that died from GBMs in the 20s, in the teens and 20s, what you notice about the autopsy drawings is just how diffuse the tumors are, and there's a reason for that, because you know we had no imaging of radiographic imaging then of any significance, with CAT scans coming into popular use in the 70s and MRI in the mid to late 80s. You know, other than arteriography you just didn't see primary tumors. So I think the pathology you saw on these specimens was end-stage disease. And so multiforme just meant diffuse or all over the place. What we often see as, one isolated tumor or a few isolated tumors. It almost looks more like a form of what's called Gliomatosis cerebri, where the brain is just covered in multi-lobes. A glioblastoma, by our imaging standards, goes to the most commonly in the adult, goes to the temporal lobes first, followed by the parietal lobes, then the frontal lobes, and then the occiput. GBMs in the brainstem or below the or in the posterior cranial fossa are not at all common. So what we've learned about the classifications, and to this day, even with all the genetic markers and the molecular biology we do understand now, the gold standard of classification and histology, according to the World Health Organization, is still morphology and histologic description of structures. But with the advances we've had in imaging and the molecular biology, we know that there are now basically two separate types of glioblastoma multiforme. There's the primary type, which is occurs in older patients, and usually it's I'm sorry, this is a typo. It's EGFR positive, endothelial growth factor positive, and it's in older patients, meaning greater than I think it was greater than 55 years old. You'll often see P10 mutations, CDKN2A, P16 deletions, and sometimes MDM2 amplification problems. And with primary GBMs, that's the older patient, they are in many ways more they're in many ways a little bit less aggressive than the secondary GBMs. The secondary GBMs, 2/3 of them have a TP53 mutation. They have no EGFR amplification, and it's younger patients. And younger was defined as less than 39 years old, and there's a slight female preference in that younger category. And so with secondary GBMs, they are more lethal than the primary GBMs. The reason for grading the tumors, or really any kind of tumor, is to look at the morphology, which is still, like I said, the World Health Organization gold standard, and to get an idea of the prognosis and the ability to treat the tumor optimally. So the other important criteria for GBM, and this gets taken into account frequently, is age and the performance status, the Karnofsky score. Then there are issues like radiologic enhancement and other radiographic features. Dr. Shekar and Dr. Sen at University of Pittsburgh, they noted a lot of times when they were dealing with skull-based tumors, the importance of the enhancement, and not only the enhancement, but the degree of edema in the T2 images of the tumor where it abutted the dura. Another significant prognostic factor is the extent of resection. And we'll talk a little bit about that. There's a very good article from Dr. Nadir Sadnar at the Barrow Institute, and I'll show you that in a few minutes. Another is genetic alterations, the proliferation indices, and of course the Karnofsky score. Now, with a performance score, you know, because the glioblastoma has such a short survival period, usually between I would say 16 months to about 6 months to about 15 months often, but usually around a year oftentimes, that if somebody's really significantly impaired prior to surgical intervention, it's probably not a tumor that you ought to be operating on or debulking significantly, because their condition going into surgery is the best predictor of what they will be like coming out of surgery. To this day, radiotherapy is still the most effective adjuvant with glioblastoma. The standard dose of a GBM is 100 centigrade fractions, 180 centigrade fractions to a total dose of 60 gray, to treat the bulk of the tumor and the area up to where you see the margin of increased signal. And that kind of accuracy is going to be achieved with stereotactic radiosurgery of some sort, be it gamma knife or a LINAC. GBM and chemotherapy has not, it's advanced, but it's not as effective. We see response rates in the 30 to 40% range, and survival is increased by, quote, a few months. Temozolomide has changed a lot of the scope of it's an oral agent. Be efficacious in high-grade gliomas. You know, it's been now over 20 years since Dr. Brem had introduced the gliadil wafer, and the gliadil wafer was, in some ways it helped, but it was an implantable chemotherapy, and overall a lot of people weren't helped by it because there was a lot of wound breakdown and dehiscence of the incision. So you'd have these people that didn't have a whole lot of time left, spending that time in a hospital, reclosing wounds and having plastics or ENT assist with the dehisced wounds. So I think the temozolomide has been a good addition. Now, this was more for the medical students. You have to listen to the questions. You'll often be asked, what's the most common primary brain tumor? It's a GBM. But that's not the same as what's the most common intracranial tumor, because that still remains meningiomas, followed by Mets, and glioblastomas come later. But GBM is the most primary brain tumor. Now, with the designations of primary versus secondary brain tumors, or GBMs, primary GBMs, as we talked about, occur in older patients, and it's usually a short duration of symptomatology ahead of time. But the secondary GBMs are often changes in the biology of a much lower grade glioma, so that a grade 2 or grade 3 glioma, which are often called benign gliomas or referred to as benign gliomas, are really not benign. With the diagnosis of a benign glioma, you're still looking at a 5 to 10 year lifespan. So they're not as benign as the name implies. So you can have a much less aggressive tumor with much more benign histology, change their biology and turn into a GBM, and that you're at risk for that with these secondary GBMs. Now, we hear a lot about glioblastomas, and one question. This was from Remy Nader's book on neurosurgery questions and the neurosurgery knowledge update. Remy had asked the question: do GBMs invade the subarachnoid space and metastasize via CSF? And the answer to that, for the most part, is no. We have seen peritoneal metastases via VP shunt in children and some adults, but those are more for the primary neuroectodermal tumor types, not as much so for GBMs. So you don't really see the invasion of dura and bone like you would see in prostate CA or breast CA. You don't see excursion into the vessel lumens and venous sinuses. Those are the exception rather than the norm. So in today's treatment regimens, we're still looking at surgery followed by radiotherapy and temozolomide, because there is a good response in the 30 to 40% of people that do respond. So the question now is, well, what's the value of surgery in a glioblastoma? And the opinions on that change, and it's still a big debate. The other issues with glioblastomas are what's the driving force for the way that angiogenesis takes place in glioblastomas. And this was this is all information that's come about in the last decade or decade and a half. Hypoxia is what drives the glioblastoma's vessel production. So intracellular stabilization of the hypoxia is affected by regulating gene hypoxia inducible factor 1 alpha. And that activates over 100 genes that control the angiogenesis of the GBM. So in other words, you have over 100 gene activators for angiogenesis in the glioblastoma model. Now, the thing that seems to drive the hypoxia is VEGF, which is the breakdown products and the buildup of hypoxic tissue that triggers the system and also triggers the tumefactive liquefaction in GBMs, the areas of necrosis. So with GBM, it's like any cancer. You have Gompersian growth, where the tumor eventually grows to a size that it just outstrips its blood supply, and that's when it begins to necrose. Now, with GBMs, there are a few variants, and I think you'll find sometimes gliosarcomas mentioned as a type of GBM. That is a really highly malignant type of histology. And then this next phrase, the gliomatosis cerebri, it's spelled wrong. It should have an I on the end, not an A. Gliomatosis cerebri is a lot of what you're reminded of when you look at Harvey Cushing's drawing of Louise Eisenhardt's postmortems or autopsies of patients who died with late disease or didn't really come to attention until they had significant diffuse spread of the tumor, so that the gliomatosis cerebri almost looks like the entire white matter, especially, is just covered in tumor. It just looks like the entire cranium has tumor in it. Now, this is this week's New England Journal of Medicine. It just came. I just got it yesterday, but in this week's journal, there's an article called Multiple Molecular Data Sets and the Classification of Adult Diffuse Gliomas. And I haven't gone through that yet. I looked at some of the graphs. But, you know, we're getting better and better with the molecular biology and the markers for the tumor so that we're able to classify things much better than we had been. This paper by Lacroix in the Journal of Neurosurgery, it's already 14 years ago. This was a very good study, a multivariant analysis of 416 patients with GBM, prognosis, extent of resection, survival. This paper was a very important paper because it did show that with a significant degree of resection, there was a statistical difference between those who had surgery, debulking surgery, and those that did not. Now, this is 14 years ago, so I think significant debulking then was considered, quote, 78% of tumor bulk removal. Now, when you look at some of the literature today, some of the criteria is up to a 98% removal of tumor, and you have to take that in some ways with a grain of salt because it's 98% of what is visible radiographically via MRI or PET, but I don't think they're talking about margins of resection because it's a molecular disease. It's not it's hard to know how much you've resected when you can only see a certain portion of the tumor with dye but they're talking about extreme resections. And a friend of mine actually did have a really significant resection of a corpus callosum GBM recently, and he really felt that it had added months onto his lifespan. He happens to be a neurosurgeon. Now, there's an excellent chapter by Nadar Sinai from the oncology section of the Barrow Brain Tumor Research Center, and that was in a textbook by Dr. Gogwala called The Evidence for Neurosurgery, and Chapter 19 is the evidence for surgery of glioblastomas. So when you're wondering why neurosurgeons or why you're operating on a tumor with such a high morbidity and mortality, I think it has been shown that in select patients where you're able to resect as much tumor as possible, you are buying those people time. And a friend of mine did say to me that he really appreciated his surgeon's efforts at debulking this tumor because it gave him more time to spend with his wife and children.
Richard, can I ask a question real quick?
Yeah.
Yeah, sorry to interrupt, but before we leave this screen, now, it has to do with the classification. So the earlier classification of the tumor, the better survivability and better outcome?
The lower the number?
No. If you want to classify a tumor as quick as possible, correct?
Well,
or does it matter? Doesn't matter.
Yeah, you're kind of, you're dependent on the technology you have at the time.
Okay.
So, in 1910 and 1920, when Cushing and Eisenhart were looking at these people, they didn't have technology. They weren't seeing these tumors grossly unless they were in elegant areas that caused neurologic defects and were then brought to attention and had surgery. The people that started with a tumor in a non-elegant place probably, it seems, had a quiescent period where that tumor had more time to grow and proceed. But, with all the molecular biology we're learning now, maybe these tumors are very unlikely incurable once you get a certain to a certain volume or dissemination. I don't know. But yeah, you would think that the earlier you diagnose the tumor, the better off you are. And intuitively, that sounds right, but that would be hard to prove statistically. I mean, that is now a big issue with women and breast cancer, and the issue about mammography, how often it should be done, what the downsides of mammography are, because there are some tumors you're not curing. Doesn't matter how early you get it, you don't seem to cure some of them. And once you have a diagnosis of a GBM, there's very little that's going to be helpful to you, other than time, giving you something that's going to buy you a little more time.
Richard, we have someone coming on board with us, Fike Sheikh, S-H-I-K-H, he's MD, he's a neurologist from University of Pittsburgh, but he just did a fellowship in molecular imaging. So I'm sure that you guys will have some good conversations about brain tumors and molecular imaging. Okay, we lost that a little bit.
A friend of mine has been training in molecular biology for years now, so he's certified and ready to go. So hopefully we're gonna get some information that's going to be helpful. Mm-hmm. Maybe we could change some of the statistics of the disease, but I mean GBM's just awful.
Right. Okay.
The only good thing, that's the only thing I've seen so far. But it's interesting. It's such an aggressive tumor, but it's in contradistinction to like the head and neck cancers we see. They're so destructive. It's very much like the pancreatic cancer of the brain, except it doesn't hurt. I mean, it ruins the brain, but it seems to preserve all that tissue, everything but the brain. But it ravages the brain, But it doesn't destroy. Doesn't eat through bone. It doesn't do the kinds of things that other aggressive tumors do. I think I'm not sure. Yeah, I think really that was about it. I mean, the classification into primary and secondary really is based on age and whether the epithelial growth factor pathway is affected. That's what makes you a primary GBM rather than a secondary GBM. The secondary GBMs, though, are awful. The friend of mine died. She was only 50 years old, and you know, it was a tumor that just wasn't responsive to much. You know, this is it. 2/3 have a TP53 mutation, but there's no EGFR amplification. So, you know, they're a miserable tumor to treat. So.
Yep.
Do you see it? Go ahead, Ben.
Yeah, Dr. Mendel, I know this is a very aggressive tumor, and I mean, it's very hard to treat. I'm just wondering, what is it making it so hard for this tumor to treat? Is it the size, or is it the duration, or is it the types of cells that are involved, or is it the location?
Well,
or some. Yeah, go ahead.
You gotta get off that screen share, Richard. Just click on the green arrow, Richard, to get off the screen share. There you go.
That's what I'm
there you go.
Okay. Well, yeah, it's really not the location. You know, the location of the tumor with GBMs, like I said before, it's most common in the temporal lobe. And, you know, a dominant temporal lobe is devastating. If it's, you know, anywhere but the 3 centimeters in the tip of the, if it's in the tip of the temporal lobe anteriorly, you have some time. But temporal lobe is a terrible place, especially if it's the dominant side. But the second most common distribution would be in the parietal lobes, followed by the frontal lobes, and then the occipital lobes. And I'm not really sure why it is temporal and parietal before frontal, because frontal is the largest area, but it's not. It's temporal.
I've got a question at that point, Dr. Mendel. I'm just wondering how the cell phones might be related, you know, in causing the incidence, because you know, we keep close to the temporal lobe and also the parietal. I mean,
is there any studies on that?
Anything that's making it worse?
On which?
Cell phones causing brain tumors.
Cell phones? No. That got looked into many times. I really didn't think there was anything strong. There was no statistical causative features. There were some correlative features, but not causative.
Mm-hmm.
Or so
it's been the most common primary brain tumor for over 50 years now, and we haven't affected it very much. We learned a lot though. The clinicians that do a lot are like Mitch Berger at UCSF, Dr. Spetzer at the Barrow, who has the skills to resect these things down to margins of a few percent, and Dr. Berger, who really does so much functional imaging ahead of time. That's helpful a lot.
Yeah, Richard, does early diagnosis help at all, or it really doesn't matter? Once it's established, that's it?
I don't know that. I don't know the answer to that. I mean, I have a feeling that diagnosis may not
have much to do with
as critical as people think. But certainly you don't want to diagnose it when Harvey Cushing and Louise Eisenhardt are looking into the dead skull.
Yeah.
But, you know, if you had some kind of imaging, would there be a difference whether there was a 2 or 3 month delay? Maybe there would be. I don't know that. I really don't know.
Okay. Okay. Sajesh, do you have any questions? You have to unmute, Sajesh. Unmute, Sajesh. Yell at your dad to unmute. There you go.
Yeah, all right. Sorry.
It's all right. Everybody makes that mistake.
Richard, that was a wonderful presentation. Just gave us a lot of insight into this nasty tumor. I'm happy that at least radiotherapy has got some effect on the tumor. But I mean, you were talking about a lifespan of about 6 months to about a year for this kind of tumor. And I was wondering, when you use radiotherapy or chemotherapy, and or use surgery, I mean, what kind of a life expectancy are you achieving?
But that's the excellent question. That's the question. When you can look at this data and try to pick and choose, but when it comes down to it, you have to think of it as what's the patient's performance scale. And if you've got an older person with a low performance scale, I couldn't resect enough tumor that I could make it worth their while, I don't think. So if the performance scale is low, you really want to err to the non-operative side. If you have somebody with an excellent performance score, no matter what their age, you probably want to give them the best shot you can. But it's all the location of the tumor, how functional the person is. If it's an older person, statistically, you know that their survival is going to be harmed by their age, but that's how you treat a group of people. But as an individual, if you have a 90-year-old who looks like a 65-year-old, you're probably going to want to try to give them the best job you can, but you've got to, you have to go in there with the mind that you're going to resect as much tumor as you can, and I really think in some ways that's more suited to an area where they're doing a high volume of them, like at UCL, CSF or the Barrow. My friend, a neurosurgeon, went to Dr. Spetzer to have the surgery done, and Dr. Spetzer just resected an incredible amount of tumor, and the guy's doing great, but I don't think they'd be doing as great as if I resected the tumor.
Yeah. Thank you, Richard. That answers my question.
Okay, Simon?
Yes, please. Thank you. I'd like to just start with a basic question. What's the difference between SP53 mutation and P53 mutation, or are they the same?
SP53 and NP53? I have to look.
I think you said SP53 mutation.
The P53 I think you meant I think I meant a P53 mutation.
Oh, I see.
Yeah.
I see. Well,
I may not have spell checked these slides. I actually finished them minutes before we got started.
Oh, I see. No, I understand. Well, the question is, of course, we're hoping that we would be able to, hopefully one day stop these P53 mutations. But in considering that we can't, what happens? I'm interested in what happens to the patient as the GBM progresses, and what does palliative care do?
Well, I think the only blessing about GBMs is that I've never really heard anybody complain of pain with GBMs, except my friend had some unusual headaches, which is what drew his attention to getting the scan. But with a GBM, you're dying from an expanding mass in the head, and you usually go very quietly, and it doesn't seem to be as dreadful as a lot of other things.
I see. Thank you.
Richard, what role, I may have missed it, what role does gamma knife, does it have a promising role, you think, or there's been nothing positive done with gamma knife?
I think that as we're getting better, as our technology gets better, we're learning more. Like, the radiation oncologists have chosen an optimal dose of centigrade.
We're losing the sound, Richard. We're losing your sound.
I don't know why.
There you go. Okay, there it is. It's okay. It's fine.
Well, the radiation oncologists have an optimal dose treatment plan for the GBM.
Okay.
Now, you have to remember, with a gamma knife treatment, the delivery of the radiation great. Same as it is with a LINAC or any stereotactic radiosurgery. The deliveries to the tumor is great, but you do get to a point where the tumors are too large to gamma knife. So I think that people are still using degrees of like a booster dose to the bulk of the tumor, and then using gamma knife and stereotactic radiosurgery around the thinner margins of the tumor. But I think that in time, we're not going to be doing gross, radiation therapy. We're going to be. I think stereotactic radiosurgery is going to be the way we deliver radiotherapy in the future. But we've got to get better at it in terms of the gamma knife, the what's it called? The cyber knife, or all those other brand names, the Trilogy. They're great for delivery of radiation, but they're precise tools that you would use it would be like the difference between using a roller to paint your walls and a tiny little
paintbrush, yeah.
So you're using the tiny paintbrush for the margins and the elegant areas, but you're going to still use the roller.
Very good.
Dr. Mendel, I have one more question. I'm just wondering why a patient doesn't get headaches, more frequently. It's not described. Like I'm looking at the literature. Nausea, vomiting, or the raised intracranial pressure kind of symptoms.
Yeah.
Even though it's so aggressive, it's supposed to be causing these symptoms.
Yeah.
Right. So what happens is you have the growth of the tumor, but you're not irritating the meninges, right? So with the meningioma, you may get bad headaches, right? Because that's where the pain sensors are. But in the brain where there's no pain sensors, the tumor can get really pretty big until it disturbs the meninges or blocks CSF, and you start getting spinal fluid headaches. Or I really, I can't tell you why one person has symptoms or why another doesn't, but I think a lot of it has to do with whether you're on pain-sensitive tissue or not. If you're on the meninges and you're stretching the meninges, you're going to have pain. But if you're within the brain parenchyma itself where there's no pain fibers, you're probably not going to feel anything until, the Monroe-Kelly doctrine gets invoked, where either you have, when you get to a point where you have CSF, blood, or brain, and brains, brain tumors compromising blood or CSF, then I think that's where you get your symptoms. But I think that it's not, for a lot of patients, families, they're comforted by the fact that people kind of slip away and they don't. It's not an agonizing end. I think that's at least easier for the families.
Thank you, Dr.
Very, very good, Richard. I guess we'll wrap it up now. Thank you very much, Richard, for an excellent presentation again, and thanks to all the members of the panel for coming out. And
thank you very much.
We'll see you. Thank you, Richard, and good night.
All right, thanks a lot.
Thank you, Dr. Mendel.
Thanks for the panel for coming out. Thank you very much.